We're going to go into the anastomotic leaks that happen with obesity, and then we're going to talk about sepsis and a little bit about PCA pumps. Okay, so the obesity diagnosis carries with it a lot of complications, and we're going to go through that by body system. So if your patient is obese, these are all the different risks by body systems of the diseases that they can develop. So in the lungs, we have asthma, obstructive sleep apnea, we have upper respiratory infections. In the thyroid, we have cancer. In the heart, you have coronary artery disease, heart failure, myocardial infarctions, hyperlipidemia, and then hypertension. So most of the heart and the obstructive sleep apnea have to do with the increase in interthoracic pressure based on the amount of weight that's on top of the abdomen. Okay, and then in the liver, we have non-alcoholic fatty liver, we have cancer of the liver, and then kidney cancer, pancreatic cancer, and then in the gallbladder, you have cancer, stones or cholelithiasis, or you have cholecystitis or inflammation of the bile ducts. And then in the colon, we have cancer. In the bones, we have osteoarthritis. And for men, we have prostate cancer. And then for women, all of the gyne cancers. So breast, endometrial or uterine, and then ovarian cancer. So if there's any kind of overarching theme with obesity, it does carry a pretty good cancer risk for most of the body systems. Okay, so to be diagnosed or classified as obese, it has to do with the patient's BMI, okay? So, and when we talk about BMI, we talk about your body mass index. So it has to do with the ratio between the height and the weight, and the mass, total mass versus the height-weight ratio, okay? So in the body mass index, you can look this up and have your BMI calculator done for you. You don't need to know how to calculate this. So if you have a BMI from 25 to 29, you're considered clinically overweight. If you have a BMI greater than 30, you're considered clinically obese. A BMI from 18 to 24 is considered normal. You're at a normal weight, okay? Meds for obesity, so these are not a long-term solution. We're going to want to really supplement with some sort of psychotherapy, counseling, things like that, okay? So we want these people to kind of get to the root of the problem as to why they're using food as a compensatory mechanism. Just like any other addiction, this one I would say might be slightly harder because those other addictions, you can get rid of that illicit substance that you're putting into your body, and your body can live without it and do better without it. But with obesity and other food type addictions where you have a poor relationship with food, you have to eat every day, right? And so these people can't just get rid of their addictive substance. Their addictive substance is the thing that keeps us alive. So that's a bit of a problem, and it comes with it. It has to come with it quite a bit of compassion for these folks, because this is pretty tough, right? So we got to do some sort of mental health component with their medications and their medication type treatment. Orlistat is kind of one of the over-the-counter ones. That is an advantage to it. It's over the counter. It's known as Ally over the counter. That's its brand name. Orlistat is kind of the off-brand name. It decreases fat absorption in the gut, so specifically in the small intestine. But along with that, it does help quite a bit with weight loss, but because of that, the oily discharge has to go somewhere, and so most of the time you excrete it through your colon, your large intestine, and so then it causes oily anal discharge. Frowny face, right? That's a major frowny face. It also causes quite a bit of GI upset that has to do with gas, bloating, constipation, sometimes diarrhea in some folks, so it could go either way. And that oily anal discharge can also come out every time they flatulate or fart. So this can come with quite a few risks, not risks as far as, but just being inconvenient and unpleasant, right? That oily anal discharge is kind of enough for most people to say they don't want to do it. So, but it is available over the counter. All right, lorcaserin increases serotonin. It decreases appetite, but it does carry with it some side effects that are unpleasant. It makes you dizzy, constipation, tired. And then phentermine is kind of the upper or sympathomimetic that a lot of places use, and that increases our metabolic rate and decreases appetite. So then you eat less, therefore you lose weight. It's a sympathomimetic similar to meth, obviously, but it's not meth. Okay, so but you can kind of think of it in those terms as far as the risk factors that you go with it. So it's going to increase the heart rate, blood pressure, cause some ECG changes. Okay, it's only effective, this is another disadvantage, it's only effective for 2 to 3 months in most patients, in all patients, and then you have to take them off of it, and then they have to be off it for about 2 to 3 months, and then you can put them back on it. So the body does develop a tolerance to it, and it really won't work after 2 to 3 months. So that's a major downfall. Plus, if your patient is obese and they have any sort of cardiovascular comorbidities, this isn't a good choice for them. All right, then we have phentermine and a topamax with the topamax combo medication. And so we have all the above side effects. Plus, we have with topamax, we add the drowsiness, dizziness, bad taste, and possibly diarrhea. Okay, it does decrease appetite, right? Because the reason that it decreases appetite is because it increases our inhibitory effects of the GABA system, right? So that gamma, the butyric acid one, that system, part of our neurology, will help to increase its inhibitory effects. Okay, weight loss surgeries that are available. One of the most common ones and carries quite a bit less as far as risks and malabsorptive issues is the gastric band. So they place an inflatable silicone band at the top of the stomach. So the top portion of the stomach has this inflatable band. They can increase it to what they feel is needed, and then that therefore decreases the food consumption because you don't have enough room in the stomach to fit food. And so this is FDA approved for people that have a BMI between 30 and 40. Most of these surgeries require, if your insurance is going to pay for it, the insurance companies will require a psych eval because they want to know how serious you are about this, and most places will require that you have some sort of psych or mental health component to your recovery. Okay, and so now let's go to our Roux-en-Y or gastric bypass. That's kind of the more common invasive surgery. They create a small pouch from the stomach and then they connect it directly to the small intestine. They usually bypass the duodenum, okay, and they create a smaller stomach. So if you create a smaller stomach, then you're going to eat less because you can't hold as much in your stomach. And if you bypass the duodenum, you have a less amount of that's actually being absorbed as far as fats go. But the problem with that is then we can't absorb vitamins and things that we need. So, but it bypasses the duodenum, it connects to the jejunum. This is FDA approved for people that have a BMI between 35 and 40, but sometimes they will approve it for people who have a BMI of 30 if those people that have the BMI of 30 also have a bunch of comorbidities. So if they have some severe cardiovascular issues, lung issues and stuff that would benefit, if they could get this surgery, they could decrease some of those risk factors, then they can also do it for people that have a BMI of 30 with those comorbidities. All right, so it decreases the stomach volume between 20 to 30 milliliters, which means that's like just barely an ounce of food that they can have, right? But then when we do that, because we're bypassing the duodenum, we increase their chances for having vitamin deficiencies, right? Because that's where a lot of the absorption takes place. And then we're increasing our chances of an anastomotic leak. Anytime you disconnect or cut out certain portions of the bowel and then put bits together, right, and then sew that end up, that's a very crude representation, that's called an anastomosis. And so from that, you have a chance of leaking at that site that you put back together. All right, so let's go into the one that's way less common because it carries quite a few more risks. It's called the biliopancreatic diversion with a duodenal switch. It decreases the stomach volume to 100 to 120 mLs. So here we get about 4 to 5 ounces that the stomach can hold. So it can hold quite a bit more than the gastric bypass. The only problem is that we've turned the stomach into a banana shape. So they remove quite a bit of the stomach. About 80% of the stomach's removed. We keep a small part of the duodenum, but then we bypass the rest of the jejunum and the ileum and connect directly to the large intestine. So it's a little bit odd. And then this is approved for people who have a BMI of 50 or more. because it will give them the greatest amount of weight loss. Okay, so this one is the one that has the most weight loss achieved from this one. It increases our malabsorptive problems even more than the gastric bypass, so that's a bit of a problem. And it also increases our chances of an anastomotic leak because we've cut and spliced in a few places. Okay, so that is all of our bariatric surgeries. This is the one that has the most weight loss, and usually we want people to be losing weight between 1 to 3 years from the time that they have surgery. You'll also hear the term, kind of a colloquialism that's used in medicine, and it's commonly referred to as beating the bypass. And that's when a patient has had a bypass surgery of some sort, and then they re-stretch out this new stomach. So for example, with our gastric bypass, what they can do is just gradually eat more and more and more and more, and then stretch that stomach right back out to what it was before. And then they gain all the weight back and everything. So that's kind of part of the reason for the psych eval mandated by a lot of insurance companies, because they don't really want to pay for that and then have you have the patient then gain all the weight back, right? Assessment findings of an acute abdomen. So if you have a patient with an anastomotic leak, they're going to have what's referred to as an acute abdomen, meaning that they have a surgical abdomen or an emergently problematic abdomen, right? Something that's going to cause some serious emergent problems. So they're going to have a fever greater than 100.4 in Fahrenheit or 38 or greater in centigrade. This makes them qualify as a septic patient or septic criteria, so that's why we're talking about sepsis here. They're going to have fatigue, abdominal pain, and they're going to have some major guarding and rebound. So not just abdominal pain, but it's pain that you can actually reproduce with touching. Most abdominal pain is not necessarily reproducible with touching because it's a matter of pressure or increased pressure with gas or with stool or fecal contents. But if you have a truly abdominal pain that's reproducible with palpation, that's pretty indicative of an acute abdomen. These people will be hunched over when they're walking because there's more peritoneal irritation produced by standing straight up because the bowel is touching the rest of the abdomen. And so if they can kind of hunch over, that's the natural survival mechanism that we do, where we hunch and then we can pull the bowel off of the back of the abdomen, and so that way there's not as much pain. So they'll be possibly in a fetal position in the bed, curled up, and the pain will increase if they try to lay flat. Okay, now we might see dressing change to the actual site, their post-op site, so you might see more drainage. Most of these gastric bypass patients, in fact all of them, have JP drains that are placed in surgery, and so those are those little bulbs, and it passively, or not passively, but through vacuum, it will pull out the fluid that's accumulating in the peritoneal space where the surgery was. And that's to help decrease infection, seromas, hematomas, that kind of thing. And it's used to help monitor, what's going on inside the abdomen post-op. So you'll see a change. They're going to have some serious pus all of a sudden in those JP drains, an increase in blood, an increase in the amount of drainage. And most anastomotic leaks occur within that first 5 days of surgery. Okay, and with some anastomotic leaks, your risk of having one is up to 40%. So it's pretty high for a lot of people. Okay, now our vital sign changes. So to kind of make that septic criteria, early symptoms would be with our heart rate above 90, and that's our septic criteria with a fever and an obvious source of infection. Okay, so just because you have a heart rate above 90 doesn't mean you're septic. You have to have a fever, you have to have an obvious or documented source of infection. They're going to have a lowered blood pressure. That's a late sign of septic shock, right? And specifically for sepsis, we're looking at the MAP. And if it's less than 65, they can make septic criteria. Or if their systolic is less than 100. And then if our respiratory rate is above 20, that's somewhat of an early sign, but that also makes them sepsis criteria as well. All right, now peritonitis or septic workup. So these are the diagnostic tests that you're going to be doing for these people. We're going to be doing a CBC and a specific look at our neutrophils and lymphocytes and our bands. So you'll see what's called a left shift, and that's where you have an increase in your neutrophil count. And that usually means that you're dealing with an acute bacterial infection if you have a dramatic increase in neutrophils. And then along with that, because it's percentage based, then reflexively your lymphocytes will decrease, okay? And that's what's known as a left shift. And then our presence of bands, so bands are, what are bands? Those are immature white blood cells. And so what you have happening is all of your teammates are out on the field playing. So we'll pretend that we're playing football. Everyone's playing football. You have all these players out at the same time because the game is really, really hard. You have a really hard team you're playing at, and you have extra things you have to be doing, just like in the body when they're up under sepsis. So everybody's out playing, trying to fight, trying to get everything turned back around. And then what happens is those players die off and get tired, just like our mature white blood cells. But because it's happening so fast, we don't have time for the immature white blood cells to go through their entire life process and become mature, or their life cycle, and so you just throw them out. So they're throwing out immature white blood cells to fight because they have nobody else. So imagine all the players on the bench, everybody's out on the field fighting, and then now we got nothing left, so who do we throw in there? Well, we throw in the marching band. So that's kind of what bands, that's how I describe what bands are. It's the marching band. They haven't completed their training on how to play football, and in most instances, they don't even know the first thing about how to play at all. And so you have immature players playing. So that's kind of helps me remember bands are the immature white blood cells. And that's usually a pretty ominous sign. All right, our CMP we're going to look at, because we're trying to look at liver and kidneys, see how they're doing. Our lactate specifically, or the lactic acid, those are kind of used interchangeably. If it's greater than 2, we know that that's abnormal, okay? Why are we looking at that? Well, in lactate, you're looking at for the product of the anaerobic glycolysis. If you remember, the quick way to get ATP or energy is to do anaerobic glycolysis, but it only gives us 2 ATP. It's quicker, right? The other way to give us our full 36 is with the Krebs cycle, but that takes a while. And the body's under attack, it doesn't have time, it needs quick energy, right? So it will default in sepsis and not do the Krebs cycle, it'll default over to anaerobic glycolysis. So we check for our byproducts of that anaerobic glycolysis, which are pyruvate and lactic acid. So we check for a lactic acid level because that tells us how bad off they are, right? Because if they're using anaerobic glycolysis more, their lactic acid is going to be higher, which means their sepsis is worse. Okay? Now we're going to check, make sure we collect blood cultures. It's going to take 24 hours to get results, at least. Probably more like 48 to 36 hours. Because these guys have to grow. Okay? Remember, culture means it's growing, and so you don't get instant results. You're not going to get results in 2 hours, you won't get them in 12, and sometimes not even in 24 hours. It just depends on the bacteria and how fast it's growing. We're checking for bacteria in the blood. So just like with a urine culture where you're sending urine, or sputum culture where you send sputum, we're going to be sending blood to the lab in a special bottle that has culture medium or food for the bacteria. Those are the ones that look like a Tabasco sauce bottle. They're the little guys about like this, right? Look like Tabasco sauce. Or maybe the little tiny hotel vodka bottles, right? You're going to collect 5 to 8 milliliters, depending on if it's peds or adult, usually 8 if it's an adult, into that bottle, okay? And then you get a total of 4 bottles. We want 2 sets, so 2 aerobic and 2 anaerobic. So at every site that you check, 2 sites on the body. So usually the left arm and the right arm, that's the easiest way to check. We want to get 1 aerobic and 1 anaerobic at every site. So that gives us a total of 2 aerobic and 2 anaerobic bottles. Why are we checking aerobic and anaerobic? Well, 1 bottle has the food for the bacteria that likes oxygen, right? So that's our aerobic, and 1 bottle has the food for the kind that doesn't like oxygen, so the anaerobic bacteria. So we have 2 sets, and each set includes 1 aerobic and 1 anaerobic. All right. You won't see growth for minimum 24 hours. One time, the sepsis was so bad that we did see growth in 12 hours, but that patient had already passed away because they probably came in a little late. Okay, now up to 5 days they'll keep them in the lab and they'll look at them every 12 hours to see if there's any growth. So this isn't something you can call the lab or microbiology or whatever and get results on. This is going to take a while, so don't expect to have results on these. We start them on broad spectrum antibiotics depending on where we've isolated the source is coming from. So depending on where in the body the source is, we're going to put them on appropriate antibiotics for that body site. Okay? And then we compare, once they get growth, they tell us what type of bacteria it is, anaerobic, aerobic, and what it is. Is it gram positive? Is it gram negative? Are they in chains? You know, what do they look like? What kind of bacteria is it? And then we base the treatment on that. Then we can change their antibiotics if they check and see that the antibiotic they're on doesn't work for that particular bacteria. So if it's not sensitive, we got to check into something, change them to something that is sensitive. All right, and then we're going to do a CT abdomen pelvis, and this is not for all septic patients, but this is for someone who just had abdominal surgery, right? So we would want to check to see if that's the source of the sepsis. They'll either do IV contrast or oral or both. With a UA culture, possibly, right? A urine analysis and culture, because there again, we're trying to check the kidneys post-renal in the UA, and then a culture to see if that's the source. Possibly get a chest x-ray to rule out pneumonia, because that could be the reason for the sepsis as well, and then get an ABG so we can kind of look at their acidotic state. Here's for anastomotic leaks, right? When we sew two parts together that weren't originally together, two tubes together, that's the anastomotic site, and it can possibly leak. If we have immune modulators or suppressants that the patient's on, so there are immune modulating drugs, so our DMARDs and things like that. If they're on corticosteroids, both of those things make the mucosa of the bowel a lot more friable, a lot weaker. If they smoke, that makes the mucosa a lot more friable. If they have diabetes mellitus, then the presence of glucose is higher, and so then it makes that tissue more friable. If their BMI is greater than 30 or if their BMI is less than 18. So you really kind of want to be in that happy medium. If it's emergency surgery, which I mean it is, but that does increase risk. If they have increase in OR time or the peri-op time, so the amount of time they're spending in the OR, then that risk of an anastomotic leak is going to be greater. If they have peritoneal contaminants, so we're talking about pus, poop, and gastric contents already, then that's an issue. And then, right, because then those bits will partially break down that mucosa, so it's harder to get it to take. The location, so if it's esophageal, gastric, or rectal anastomosis, then you have a bigger chance of it leaking there. I do know that some rectal anastomosis, the risk for an anastomotic leak is as great as 40% in some patients. And so so that carries quite a few risks. That's a pretty big number. We're going to talk a little bit about PCA pumps, because a lot of these patients, if they go inpatient after their gastric bypass, so the band patients may or may not stay inpatient, but the gastric bypass and the duodenal switch ones are going to probably be inpatient. And so let's talk a little bit about PCA pumps. You'll see this with various patients, not just abdominal surgery patients. So the PCA has a dose demand, and the patient, that's where they have the little clicker and they hold the button. So that's a dose on the pump that's set, and it is the dose that they get every time they push the button. Now, not every time, but in that certain amount of time that they can get a pain dose, they can push the button. So that's the dose demand. Okay, so that's the patient dose demand button. This is set up on the pump in a syringe, so it's a special type of syringe pump, and so you have to use syringe pump tubing, and then it hooks to the patient's closest Y port and on their IV fluids. Okay, this is usually governed and run by the anesthesia team, okay, or the pain management team. They'll also have a lockout interval. They have to have this because they can't just give themselves pain medication whenever they want, right, or they'd be dead. So that's usually anywhere between 10 to 15, sometimes 20 minutes. They can't give themselves pain medication before that time is up. So let's say they push it because they're in pain, and then they push it 3 more times. There's that lockout time period. So even if they pushed it 3 times in 10 minutes, they're only going to get that 1 dose. okay? So that just means that they can only get a dose every 10 minutes or whatever that lockout time period is. All right, then they may or may not have a continuous dose. Some, it's just demand, but some patients, they'll also have a continuous dose given to them to kind of help keep that pain at an even keel. And so that is already set in the pump. That'll be one of the settings that will be inputted by the person setting up the PCA pump, okay? And so then on top of that, when they have breakthrough pain, they can give themselves a dose. Now remember that the family might push the button for the patient. This happens quite often, and so you have to educate the family, hey, this button is only allowed to be touched or pushed or held by the patient. So this requires quite a bit of monitoring on your part. You have to really kind of spot check people, and you're going to be monitoring these patients on a PCA pump anyway because of the increased risk of CNS depression and sedation, and that they might stop breathing, right? And so you're going to be seeing these people a lot more often on your unit, and you should be checking on them more often. Just remember that the family might take the button away from the patient and start pushing the patient's button, and the patient might be gorked out of their mind asleep, and the family might be continuing to push the button while they're already asleep. I've had this happen a few times with patients when I worked med-surg. So this is a really big issue, and you need to really make sure that that family does not touch that button, okay? And then the risks, right? So our respiratory rate's going to decrease, oxygen percentage. And so along with this, you'll have special charting that comes along with the PCA order sheet. You have a special order sheet just for the PCA pump that dictates all of these settings, and also might include a bolus dose that can be given by the nurse or the provider. And it might be a dose on top of these things if their pain medicine's not working. They may not allow you to do a bolus dose. They may say that if this isn't working with the continuous dose and their command dose, then there's something wrong, right? If their pain is so much that they can't control it with what's already been given to them, you probably should be calling the provider about that, because they might have some underlying problem that might be worsening, like an anastomotic leak, right? So along with the charting, you're going to have to chart their level of consciousness, and they might use AVPU, they might use the GCS score. It just kind of depends on the facility. They'll also include in that order sheet reversal medications and the criteria for when you should be reversing them. So for instance, for reversing them with Narcan, if their level of consciousness dips and if their GCS is less than a certain number, right, if you can't wake them up, if their respiratory rate is less than 12, if their oxygen is consistently, below 89, then we should be probably thinking about giving them a reversal. If you can't wake them up with tactile stimulation, then yeah, we maybe should think about giving them a reversal, or talking to anesthesia about decreasing their continuous or their demand dose amount of time, okay? And then you also have medications on that order sheet to take care of nausea that comes with opiates, because that's one of the major side effects of opiates. And you also might have medications to help with their pruritus or itching, because that's one of the other side effects of opiates. So just be careful, because the pruritus orders usually are Benadryl, and Benadryl is a CNS depressant. It has not a CNS depressant, but it has CNS depressant effects. And so the two together, the opiate plus the Benadryl, potentiate each other and kind of have that increase in synergistic effect, where the sum is kind of greater than the two independently. And so you have to be really careful with that, because if you give them too much Benadryl or a normal dose along with what they're already getting, it might have an even greater sedative effect and respiratory depression. So just be aware of that.